All right. Again, I'm Dr. Laura Godat. I'm one of the burn and trauma surgeons at UCSD, and I'm going to talk to you about critical care issues with burn patients. Some of this may be a little bit redundant, but hopefully, repetition is a little bit more education, and please don't hesitate to ask questions. So, a lot of my talk is really about, this is obviously the Burn Surge conference, and so what I'm trying to do is help educate you guys on what you need to do to get your patients through the first 24 and potentially 48 and 72 hours after a burn if they happen to be in your hospital. With always that caveat of knowing that we are available and we have the Zoom conferencing and other things to help guide you along the way. But these are some good kind of ground rules to help get everybody started. So ongoing fluid resuscitation. So again, fluid resuscitation, it's really important to understand this, that we need to calculate. Now this is a starting point, and that's what I try and remind everybody of. This is an estimate of a starting point of what you're going to give your patient. This is not the rule. It's going to change. We have protocols as far as increasing and decreasing fluids throughout. So really this is just a rule of thumb as to where to start. So we use the Parkland formula, and you guys already have the rule of nines down because we've talked about it a couple of times. But you're going to use that to estimate your total body surface area, excluding first degree burns. Excuse me. So first degree burns are the ones that look like sunburns, right? So don't include that. If it's not blistered and it's just red, it doesn't go into your calculation, okay? Because what we don't want to do is we don't want to over-resuscitate our patients, okay? So we're going to get our TBSA, our patient's body weight, and then multiply that times 4, all right? Then you cut that in half, and we're going to give half of that over the first 8 hours, and we're going to give the other half of that over the remaining 12 hours. So the goal here is to maintain adequate tissue perfusion, to limit the size and depth of the wound to support hemodynamics of the patient. If you under-resuscitate a patient, you will increase the depth of the burn the same as if you over-resuscitate a patient. And that's just because that either you don't have enough blood supply to it, so it converts to a deeper burn, or you put too much edema in the burn and it converts to a deeper burn. So that's why we're trying to find a good place in between. And that's why I say this is a starting point, it's not an end point, all right? And the goal being we want to maintain good blood pressure and good urinary output. Those are your two main factors that we're looking for. So, Parkland calculation. So we'll do a little example here. In a 100 kilogram male who has a 50% TBSA, so 50 times 100 is 5,000, and we're going to divide that by 4. So we're going to give a total of 20 liters over the first 24 hours. Not a small amount, right? So over the first 8 hours, that's going to be 1.25 liters per hour, all right? 1.25 liters per hour, and over the remaining 16 hours, 625 cc's per hour. And again, this is a rough estimate. This is going to depend on how your patient's doing, but that's where we're going to start, and that's what we're going to use as our rule of thumb, is where we should be at if our resuscitation is going as planned. So what do we use, right? That's the other big question. What do you put into your patient's veins that we're going to help them with? So we use lactated ringers is the primary burn resuscitative fluid. And the thing to remember about this, just as mentioned previously, is that it is hyponatremic. And one of the things that we lose when you have a large surface area is sodium. So for patients who are started on more than a liter per hour for the most part, we will start them on hypertonic saline. So what that is a liter of LR, and we add 1 amp of sodium bicarb to it, which gives us 50 milliequivalents of sodium, all right? And that's indicated for patients with TBSA greater than 25, and if you do the calculation, that's where you're gonna be right about a liter per hour for those first 8 hours. Normal saline is not recommended because of the hyperchloremic metabolic acidosis that develops with using saline, okay? So the children resuscitation formula, so children less than 2 years old have a low storage of glycogen, and so they require a constant source of glucose. So you're going to do your burn resuscitation calculation, use your Parkland formula, and you're also going to, in addition to that, calculate what you would give for normal maintenance IV fluids. So they will get Parkland formula, 3 to 4 cc's per kilogram. You can use 4 as your starting point. It's a safe place to go. And then you're going to go forward for that. So for patients with burns over 20%, these are the patients we're looking at. So if you have somebody with a 10% burn, they don't need a Parkland formula. They can almost, if you look at how much they would need, they can pretty much drink that, okay? So 20% TBSA or greater is what we're really looking at for patients needing a large resuscitation. Again, less than that, you can give them some maintenance fluids and give them a diet, and they'll be able to maintain themselves for the most part. Resuscitation fluid management beyond the first 24 hours. So once we get past that first 24 hours, you're going to continue to adjust the fluid rate based on urinary output. And so as we're doing this, we're really watching, A, is their blood pressure maintaining, and B, are they still making adequate amounts of urine, right? So if you think you're coming down and you're gonna turn off your fluids, but then their urine output is 10 cc's an hour, maybe it's not time yet, right? So we're still watching that very closely. You're going to review key labs such as sodium, chloride, base excess or base deficit, as well as albumin. And as mentioned previously, lactates also can be a way to watch your patient and to determine whether or not you've cleared their metabolic acidosis. So this is our institutional algorithm for how we change and titrate our fluids based on urine output, all right? And so you can see that it's really, if you're maintaining vital signs adequately, then if your urine output is less than, for an adult, we use a 0.5 cc per kilogram. And so if it's less than 0.5 cc per kilogram, we're going to increase fluids by 10% or 100 cc's per hour, whichever is greater, okay? If it's a 0.5 cc to 1 cc, you're gonna leave it at the current rate. You've met your goal. And if you're over a cc per hour, right, in burns, we don't want to be overachievers. We want to be just right. This is kind of the Goldilocks in the Three Bears scenario. You want to be just right. Remember, because what I mentioned earlier, too much resuscitation can make your burns even worse, similarly to under-resuscitating patients. And that over-resuscitation doesn't always impact the burns. It also impacts the lungs, how much ARDS they end up having, increasing their risk of having abdominal compartment syndrome and other complications of large volume fluid resuscitation. So we decrease those fluids to try and reach that perfect in-between of 0.5 to 1 cc per kilogram per hour. And then if you're not meeting your goals, at the bottom there you'll notice it says if urine output is less than cc per hour despite increasing fluid rates, you need to make sure your Foley's working right, make sure that they're doing okay as far as the ventilator goes, maybe check a bladder pressure. I mentioned abdominal compartment syndrome. These are things you have to start worrying about, and then contact your physician and see what else you need to do. If your IV fluid rate is less than 250 cc's per hour, you're going to start looking at your base deficit. Have you cleared your base deficit? Has your lactate normalized? Those are patients who you might be looking at decreasing your fluids further and potentially converting to just maintenance IV fluids. And then if your urine output is greater than 100 cc's per hour despite decreasing, you might want to talk to your doc because maybe you've truly are over resuscitating that patient still, and maybe they want to come down even faster. So resuscitation fluid management beyond the first 24 hours, fluid management, right? So patients who respond, you're gonna wean them off, you're gonna give them a diet, or start feeding them enterally and help maintain their nutritional status. Those who don't respond, again, the key indicator is urine output, and you want to avoid boluses. So unless your patient is profoundly hypotensive and you need to give them a bolus because you need to save their life, if they're just kind of drifting down with their MAPS, we want to go up on the fluid rate. Bolusing burn patients is just as bad as, again, under or over resuscitating, because when you have a burn, you have to think of your capillaries as having lots and lots of holes punched in them. You're just leaking like a sieve. So all you're gonna do with that bolus, it's gonna be gone really, really quickly. So those are patients where, maybe you need to call us and see what's going on, look at a CVP, look at some other advanced monitoring to see if we need to maybe even start a pressor, or maybe we need to make some other adjustments to what's going on. And that's gonna really be a very individualized assessment. That's gonna take some more specialized, higher thought process going on. And then fluid options, like we said, LR, hypertonics. We don't give albumin within the first 24 hours. We really try not to give it within the first 48 hours. We will give FFP or other colloids. So that's what we're referring to when we say colloids are advised during the resuscitative fluid. We're not referring to albumin. Albumin, the molecule is actually so large that it will go through all that capillary leak and it will make your edema even worse in the end. So diuresis of resuscitation fluids. We don't use, so once we're done resuscitating our patients, for the most part, Lasix is not part of the process. So we very rarely will use that unless we feel like somebody's truly been over-diuresed or we have something else going on. Weight gain of up to 20% is expected. So this is normal. Your patient's gonna, forgive me, I spent a lot of time in the South, but you're gonna pone up like a toad. But that's truly, you're going to swell up. All those pictures that you saw earlier is people who you just get a lot of edema. That's completely normal. They will start to spontaneously diurese within that 24 to 48 hours. And so that's where when you're coming down on your IV fluids and your patient's still making, now they're making 200 cc's of urine an hour, maybe you can come down a little bit faster because they've sealed their gap, their capillary leak is sealing, and they're really coming around the corner. And this may be delayed if they have a really big inflammatory response to their burns or had a kind of were initially unresponsive to your fluid resuscitation. So sometimes the inflammatory phase lasts longer than that 24 to 48 hour period. Again, every patient's a little bit differently, so you have to kind of gauge what's actually going on with the patient at the time, especially really big burns or patients with inhalation injuries. Those are the other ones that you have to pay attention to. So complications of excess fluid administration, generalized tissue edema decreases function to all organs and contributes to multi-system organ failure. So over-resuscitation is a bad thing, right? Pulmonary, you get true pulmonary edema is very uncommon, and kind of as time goes on, you get later lung tissue edema, with the hypoproteinemia that occurs, and that contributes more so to the ARDS. Again, patients are losing not just their fluids, they've got protein leaks. This is a huge shift in their fluid change. It's amazing, people forget our integumentary system is our largest organ system, right? And it really does a huge job for us at all times. So when it gets hurt, we take a big hit from that. From a cardiovascular standpoint, CHF from resuscitation is very rare, except for in the elderly or if this was a pre-morbid condition, all right? Young kids, young patients, for the most part, from a cardiovascular standpoint, will not have congestive heart failure from this. So abdominal compartment syndrome, this is something to pay attention to, right? If you're giving your patient 1.5 liters to 2 liters of fluid an hour, you can imagine that all that edema not only is going to the tissues, it's also going to the bowels and the viscera, and they're accumulating ascites. And so these are patients where if you're having troubles all of a sudden ventilating a patient, right? You're not getting your tidal volumes in, you're not able to oxygenate them. You check a bladder pressure and it's 35. That patient might have abdominal compartment syndrome. It may be due to the fact that they need escharotomies because you have full thickness burns on the abdomen, or it may be the fact that they need to actually have a decompressive laparotomy. Patients who end up needing a decompressive laparotomy, this is associated with a very high mortality. So bladder pressure for big burns is a good thing, and we do this routinely. We will measure bladder pressures every 6 to 8 hours, sometimes more frequently if we're really concerned, during that initial resuscitative phase. And if they're greater than 20, it's suggestive of either impending or abdominal compartment syndrome occurring. So again, abdominal compartment syndrome, this may result in hypotension, right? So as your pressures in your abdomen increase, you decrease your venous return, which therefore decreases your cardiac output. As you decrease your cardiac output, you get more fluids, then things continue to get worse, your urine output goes down, and as that pressure builds, you have pressure on the diaphragm, and pretty soon you're trying to ventilate and oxygenate your patient, but really all you're doing is ventilating and oxygenating dead space because you can't get enough air in to move it and to actually do what you need to do. So this is, if you don't recognize this and treat this early, it's truly associated with increased mortality. So extremity burns. So edema formation, again, continues in the second 24 hours, right? The peak of swelling is really at kind of 24 to 48 hours for everything. You know, think about when you've sprained your ankle or hit your thumb with a hammer, you looked at it, excuse me, you looked at it the first day and you're like, oh, that wasn't so bad. And then you get up the next day, you're like, oh, a little swollen. Day 3, you're, you know, you can't fit your shoe on your foot, right? So that's the same thing, it's just on a global basis for your entire body. So edema formation continues. And so you want to monitor pulses hourly, and especially with patients who have circumferential burns to the extremities. So we put these patients in, we elevate their burns, we'll put them in a Murphy sling, and it's okay to have them exercise and use range of motion, either in that or intermittently, but do you want to get me some water? Apologize. And so it's something that you really have to pay attention to. If they have full thickness burns, these are patients who will likely need escharotomies for their extremities, especially if they're going to have a large volume resuscitation. These are patients you have to watch very closely. And so patients, the other thing to remember is that even though you've done an escharotomy, patients are still at risk for developing compartment syndrome or requiring a redo of their escharotomies. The picture that I think Catherine showed earlier where you saw all those hash marks, and it looked like a checkerboard, right? I was actually involved in that patient, and the initial escharotomies worked, but I got called about 8 hours later because the patient was having increased peak airway pressures, they weren't breathing over the ventilator, and you could see where the patient was being restricted and the mechanics of their respiratory system were not working. So sometimes you have to redo it if it didn't work the first time. So, you know, don't feel safe in the fact that, oh, I did it, that's not, you know, put that to the side. Again, Murphy slings, anything that you can do to elevate the extremity to help decrease that edema and to help optimize the patient. You need to make sure that you're recognizing compartment syndrome. So the 5 Ps of compartment syndrome: pain, paresthesia, pallor, pulselessness, and poikilothermia. Well, poikilothermia, cold extremity, it's going to be late and you're not going to really, it's hard to recognize that in your burn patient. In somebody who's awake, pain is going to be the key thing. If a patient has kind of pain out of proportion and it's accelerating, and those are the ones you need to worry about. The pulseless or paresthesia, the one that has a numb extremity, it's too late, okay? If you've killed off the nerves, you're behind the 8 ball on those patients. So you really want to be on top of this. All right, moving on to cardiac issues. So with proper resuscitation, cardiac output will normalize within 24 to 36 hours, but with any trauma or big insult, there is change that happens. Even the young will have some cardiac depression due to the injury and the inflammation and the insult itself. So after 36 hours, you'll show, you can see on this graph here, cardiac output initially is depressed, so 1 is what you would expect. Initially you have depressed cardiac output, and then you'll rise again after 24, and then as time goes on you'll actually increase your cardiac output as they're recovering. That's where people get more and more tachycardic over time. And the challenge really is the changes in metabolic rate and cardiac output are proportional to the extent of injury. So, you know, a 30-year-old in the ICU who's got a 50% burn, I almost expect them to have a huge cardiac output, which means they're going to be tachycardic. They're going to have a heart rate of 130. That's kind of what I, in my mind, have as my young person new set rate for heart rate. You know, they're in this huge sympathetic and metabolic overdrive, and so that's not uncommon to see that in patients. So invasive monitoring, so this can be helpful, again, in these really big burns where you're accelerating your fluid rates and you're having a hard time with blood pressure or urine output, and you need to determine, you know, maybe this is somebody with other comorbidities that you need to figure out, is it really my fluids, or is this patient actually now going into renal failure? You know, what is it that I need to actually do? And so using some invasive cardiac monitoring can be helpful, especially when the initial fluid resuscitation has exceeded 6 cc's per kilogram TBSA. So if you are at 1.5, your initial calculated rate, we're going to be thinking about doing some other more kind of advanced maneuvers. This is where at our institution we'll start thinking about putting patients on CRRT and doing FFP infusions and other modalities that maybe that patient is now needing, we need to work on getting them either transferred or doing something different with them. So this is especially true for the elderly, patients with other pre-existing cardiopulmonary disease or really extensive burns or inhalation injury. Again, inhalation injury can add about 20%, sometimes more, to the overall resuscitative needs. So if you calculate somebody who has a 10% TBS burn, but they've got a horrible inhalation injury, you may actually need to be doing more than twice what your initial calculation was for resuscitation. So the goal here really is to normalize cardiovascular function. So you want to correct any hypovolemia, make sure your CVP is greater than 10. Watch your ventilator, make sure high PIPs and PEEPs can actually raise intrathoracic pressure and mask hypovolemia. And low cardiac output, which is common in large burns, you want to really only consider vasopressors if the hypotension continues to be refractory to volume loading. So if you've resuscitated the patient, if their CVP is 15 and they're still hypotensive, that's somebody who likely is going to need a pressor. Arrhythmias, the most common one would be sinus tachycardia. So airway management, we've heard a little bit about this already. The need for intubation really needs to be recognized early. And again, this is because swelling is going to come and you're not going to be able to get that airway after the first 24 hours. So if it's somebody who's going to need a large resuscitation, even if they don't have extensive facial burns, they may need to be intubated anyways. Okay, so it's something to always be considering. If they're not already intubated, you need to frequently reassess the patency of their airway, especially those with neck or facial burns. And if intubated, they're going to need frequent suctioning to maintain patency, especially if they have an inhalation injury. There's a lot of sloughing of cells. They're going to have a lot of kind of respiratory secretions. And then make sure you're using your end-tidal CO2 as well as your routine pulse oximetry. So, because this is what somebody can look like, right? The burns on this gentleman's face are not terribly deep, but they're significant enough and the rest of his body is bad enough that he has obviously blown up. You can imagine this would be a very challenging airway to obtain if he were to lose his ET tube. So the edema, again, is going to typically peak within 72 hours, right? It's the sprained ankle kind of analogy. So you want to elevate the head of the bed to reduce edema. And obviously, this patient is not somebody who you want to extubate because their airway is going to be at risk. And then use bronchoscopy to kind of assess. So oftentimes, if we have somebody with a lot of airway swelling and we're wondering, or maybe it's come down, but we're not quite sure, we'll do bronchoscopy and we'll do an upper airway examination in order to evaluate if their airway does look like it's still affected. And so, you really want to think critically about whether or not you extubate this patient to make sure you don't lose their airway. And again, continued airway assessment. So this is somebody with a bad inhalation injury. You can see all the sloughing of that mucosal lining of their tracheobronchial tree. And so it's just like the burns that you have on the outside. If you have a bad inhalation injury, you have all the sloughing and all the skin cell changeover that you may have on the outside. And so these patients need bronchs every day to clean them out. They need aggressive respiratory therapy and clearance therapy. So these are patients that need very meticulous respiratory care. And again, under-resuscitated patients may not show airway edema initially, but it will come on at some point. So again, doing good pulmonary toilet and using your pulmonologist and bronchoscopy. So the other thing is oxygenate your patient, and permissive hypercapnia is okay. So maintaining a pH greater than 7.2, regardless of what the CO2 is. That's what that means. So if your CO2 is 60 and your pH is 2.5, and that's what you have to do to get them oxygenating, it's okay. As long as patients' pH is greater than 7.2, for the most part, all their proteins and all the other enzymes that need to function can function at that level. You can use different modes of ventilation, pressure control, low volume ventilation. We use APRV and inverse ratio ventilation in order to make this happen. Pneumonia. So patients with inhalation injury are certainly at high risk for pneumonia. However, you don't need to give prophylactic antibiotics for this, okay? So if they do develop it, it does increase their mortality by 40%, especially when superimposed by an inhalation injury. So, increase sputum, those sorts of things, be aggressive about getting cultures and diagnosing pneumonia and treating it if it's there. But prophylactic antibiotics, just like with anything else, don't really play a role in this. So other issues, renal. So it's really important to maintain urine output. We've already talked about this is kind of Goldilocks in the three bears. We want it just right, 0.5 to 1 cc per kilogram per hour. And so the most common etiology of renal dysfunction in the burn patient is hypovolemia. All right, and so this can decrease your GFR. So you really want to keep an eye on the creatinine, calculate what the creatinine clearance should be, and be on the lookout for impending renal failure, especially in patients who may have some pre-existing chronic renal insufficiency or the elderly. Nutritional support, super important. This is like, for us, this is part of the ABCs almost. The patient will have a feeding tube before I turn around when I get a patient into the burn unit. It's that important. We get them a feeding tube right away, we get feeds going, and we start feeding patients and feeding the gut immediately. And we know that that's protective for our burn patients, especially for the gut. So we want to make sure that they've got good composition of protein, carbohydrates, fats, and you're going to monitor nutritional labs with daily weights, calorimetry. It's a little bit in debate in the literature right now, the use of albumin, prealbumins, but you're going to be watching and following their nutrition. The thing is, you want to get them the nutrition that they need, and you want to get it to them early. Early feeding, again, is essential to the burn patient. It prevents burn ileus from forming, so keeps the gut moving. Reduces translocation and sepsis, so it's protective. And feedings may be initiated during the resuscitative phase. You don't need to wait till day 3. This can be started immediately. Hypermetabolic state in burn injury. So this results in tachycardia, elevated energy expenditure. This is a huge stress on the system, obviously. And so you have increased oxygen consumption, proteolysis, severe nitrogen loss, lipolysis, insulin resistance. Patients who don't have diabetes may need to be on an insulin drip because they'll have hyperglycemia. And so you really need to watch for all of those things and be monitoring. So point of care glucose, even in your young, otherwise healthy person, is important. So estimation of caloric requirements, you can refer to this page in your booklet if ever needed. Thankfully, most hospitals have great nutrition departments who will help with this. There's the classic Harris-Benedict equation that helps calculate how much, what the basal caloric need is going to be, and then there's a multiplier for burns. And then there's also some information here on if you want to use indirect calorimetry, if you have that available to you, as far as what your goals are for getting things just right. You want to be within 0.84 to 0.86. If you're above that, you're overfeeding. If you're under that, you're really underfeeding. So it's a nice thing to refer to for the most part. Thankfully, our nutritionists do this for us. So labs and exams, talked about this a little bit. Larger burns or significant inhalation injury every 6 to 8 hours within the first 48 hours, and then daily. So Chem7, MEG, FOS, albumin, prealbumin, hemoglobin, right? So if I'm watching a burn patient and their hemoglobin, they come in at 12 and all of a sudden it's 18, I've under-resuscitated my patient. Right? If they're heme concentrated all of a sudden, that's another indicator. So that's another reason why we follow that, not just for transfusion requirements. ABGs, lactates, making sure that we're getting our perfusion, making sure that we're understanding the resuscitative phase of our patient and whether or not we need more or less. and where we're at in our resuscitation. As they clear their metabolic acidosis, we know they're doing better usually. Iron studies and some of the other things on the right-hand side of the screen are really kind of adjuncts for nutritional stores. The other caveat I will mention is the anti-10A level. This is something that we use in order, all of our patients will go on prophylactic Lovenox, and so we use anti-10A levels to follow whether or not we're giving them the appropriate dose for prophylactic dosing. So electrolyte replacement, it's like with any other patient who's in the ICU. You need to make sure that their levels are appropriate. You want to monitor continuously. Obviously, when you're giving high volumes of fluids, they're at risk for having electrolyte derangements. So making sure you're replacing potassium as needed, and then beyond 24 hours, replacement will continue because of urinary losses as well as some of the more insensible losses and other things they're losing through their skin. Calcium, again, calcium, this is just like Dr. Lee said in his last slide, when patients are having a hard time, this is one of the things that if your calcium is low, cardiac function decreases, so it's a very good number to be watching. Ionized calcium is probably the easiest way to look at this, to look and see if they have a true hypocalcemia. And so this is especially important for the elderly and patients with large burns. Beyond 24 hours, again, it's going to be as needed, but something certainly to keep your eye on once you're out of the resuscitative phase. Magnesium, the first 24 hours, it's usually normal, and then you're going to have some hypomagnesemia. This is really important in your elderly patients, patients with a history of AFib. If you let their magnesium go down too low, they will go into AFib, and so a lot of times that's one of the biggest contributors to that. Same thing with phosphorus, making sure that they have adequate phosphorus. You need phosphate to make ATP. ATP is what drives all of our cells and energy in the body, so phosphate's important. And then exams, chest x-rays for those who are intubated, venous duplexes, so to monitor for DVTs. This is something that we do routinely. Patients get bilateral upper and bilateral lower extremity duplexes. You can do duplexes over burned areas. You just have to take the bandages down. It's okay, and we do that. We coordinate with our ultrasonographers to do our duplexes at the time of dressing care. Central line use, particularly femoral, subclavian, and jugulars, you need to keep an eye on those as well because they're associated with a high risk for thrombosis and DVTs. As far as anxiolytic, analgesics, and neuromuscular blockade. So for anxiolytics, patients, if they're intubated, are going to need something. And so especially for patients who are intubated, these patients can either have boluses or drips depending on what's going on with them and if you can get them to a level of sedation that's appropriate. Some patients need to be sedated more deeply, especially say that guy we saw in the picture not so long ago. We don't want to lose that airway and he's flailing all about without it. Those are patients that it's appropriate to sedate a little bit deeper. Sometimes patients just need a little PO Ativan as well just for dressing care, so this is something to consider. Analgesics, these patients need pain control, right? Burns hurt. So especially if they're intubated, this is going to be the largest component of what you're giving patients to help take care of their pain, not only from the discomfort of an endotracheal tube, but their overall burns. That being said, when burns are dressed, for the most part, they're not nearly as painful as they are when they're not dressed. Once you get rid of those big tense blisters, those are painful, as well as get them covered. Kids, for the most part, they need Tylenol. They're amazing. They'll have a burn over, bilateral legs. We'll dress them up and they'll be running around in their little wagon and just need Tylenol except for when we do their dressing care. So really getting the burns dressed and covered is the key, and then using whatever they need beyond that for analgesics. Neuromuscular blockade, occasionally, again, that patient who you don't want to lose their airway or they're fighting the ventilator, they've got a really bad inhalation injury, you're having a hard time managing them, those patients you may need to consider putting them on some neuromuscular blockade. So vecuronium is an option. Nimbex is another option for patients who have renal or liver failure. But again, these are things, if we're having to do this, certainly feel free to give us a call and we can help you out with it. A couple other quick random things. The first one is fast hugs. So every patient who's in the ICU should have a daily review of everything that's going on with them. So fast hug stands for feeding, analgesia, sedation, thromboembolic prophylaxis, head of bed elevation, stress ulcer prevention, glucose control, ventilator separation or screening for extubation, bowel function care, removal of indwelling catheters, and de-escalation of antibiotics. So every day you should be looking at whether or not you're feeding your patient appropriately, you're taking care of their pain appropriately, they're sedated too much or too little, you're taking care of their DVT thromboprophylaxis, you're elevating your head of bed, you're not letting them lay flat in bed and be an increased risk for aspiration. They're actually on the appropriate stress ulcer prophylaxis. You're maintaining glucose control. Maybe you forgot to do your point of care. They are or aren't appropriate for extubation. They're not constipated, or you're not overdoing it with their bowel function. Whether or not you can remove your Foley catheters, or whether or not you can de-escalate any other pharmacotherapies or antibiotics. And really, last but not least, this is a multidisciplinary burn team, right? You come to our burn unit, you're gonna have all of these people. So there's about 12 bullet points here, and all these different people are available and are helping with us, and there's multiple people from each of these teams, right? So there's the doctors, the surgeons, the anesthesiologists, the critical care intensivist, the nurses, the respiratory therapists, physical therapists, occupational therapists, social workers, case management, dietitians, clinical psychologists, clergy, financial support, case managers, and child life specialists. And I'm sure we're missing some people on this list. Okay, there are a ton of people. We have all of our volunteers and other people that come in and help support us. So there is a huge, this is a team effort. This is a team sport. This is not something that can be done by one individual. And so that's why if there is a burn surge or if there is something going on, that's why we're here to help, and because we're used to doing these things and we're used to having these resources. And I'm sure there's lots of questions. Or did I tell everything perfectly?